Hello and welcome back to Authentically Shawna. I'm your host, Dr. Shawna Burke. I am so excited to have one of my personal physical therapists, Dr. Holly Horikawa, who is a women's health specialist. She has been practicing all things pelvic floor for the past 20 years. And so when I asked her if we could record a podcast, I said, let's do the adult version of the health talk that we got in middle school and high school, but let's update it, make it current, and talk all things about our pelvis that we think could be common knowledge, but isn't quite yet. And we'd like to see that change. So welcome to the podcast.
Thank you for having me.
Okay, so first of all, let's talk about the pelvis and what is the pelvis and what is there?
Okay, so there's a couple parts to the pelvis. We all know our skeleton. We have a bony pelvis that actually consists of two bones that come together, joined by, three bones, I guess, with the sacrum. Your SI joints in the back, which some of you may have heard of, can cause a lot of us some problems. And the front part, which is your pubic symphysis. And within that pelvic bowl, we'll call it, there are muscles, and then there is a floor of muscles, which we refer to as our pelvic floor. That pelvic floor, if you can imagine your torso, it is the bottom of your entire torso. It cuts your body in half horizontally like your breathing diaphragm does, and it helps to control our continence. We use it. Things come through it as we urinate, as we defecate. Intercourse comes into play. Babies are held there when we cough, when we sneeze, when we lift something. There are pressures generated through into the pelvic floor. So it is really, we sit on it too. So it impacts pretty much every aspect of our lives, and we don't really talk about it until it causes a problem.
Which is why most people don't talk about it, because I think for a lot of people, they don't have problems till childbirth or when people are geriatric and they start to have issues with leakage. So we just wanted to give you an overview picture of what the parts are that we're talking about. So let's follow up with that. So pelvic floors, like what can happen to a pelvic floor and what are common things that happen to pelvic floors that people tend to start to have issues?
So to your point about different age ranges that it affects, I also want to say that you can be very young and still have these issues. And I think that is right. So if we think back to let's even go before the menses. If we think back to our bowel movements, and as a child, were you constipated? Did you have any issues with wetting the bed for longer than is what considered a normal range? That could indicate a pelvic floor issue. So we go back to that. Then for females, we start with menses, menstrual cycles. Or did you have very painful periods? Were you very heavy? Then when we go into the intercourse part, when we become sexually active, did you have pain with intercourse? Okay, maybe the first time, because we don't know what we're doing, but it is not something that should be very painful. Or even back to the menses, did you have pain with a tampon insertion? If you're doing that, did you have pain with your first gynecological exam? And then as we get into childbirth, obviously now the body has changed drastically. We've carried a baby, we've delivered that baby. If we had it vaginally, then we could have had a episiotomy or tear, just the pressure of having the baby, carrying the baby for 9-10 months. You can have things like prolapse, where your organs are actually falling down. You can have issues with your bladder as far as urgency, frequency, or incontinence.
That was my category.
And you can have still then your issues with constipation. You can have things where the pelvic floor itself, the elasticity in it kind of gives way, and you can have prolapse of the actual walls themselves. So they're no longer creating cylindrical space for your vaginal and rectal canals. There's bulges here and there. So you feel like maybe you're not emptying your bowels completely. You're not able to empty your bladder completely. You can still have pain with intercourse, and you can have painful bowel movement. You can have pain with sitting, or issues with your SI joints, low back pain, your SI joints, sacral pain, tailbone pain. At this point in our lives, we're talking about we've probably had a car accident. We've fallen on our tailbone snowboarding or at the skating rink. or something like that. And then after that childbirth, you have hormonal changes at a certain point, menopause. You also have a little bit more time. Your kids are grown up, or you're more secure in your job. You can take some time off for yourself, and you're realizing, gosh, I'm going to the bathroom a lot. And I don't feel like I can travel because I'm always looking for a bathroom. And I don't want to travel to France and have to look on the map to see where all the public bathrooms are. And so, you're noticing these things in your life. You may not have identified it as a problem, but now they're coming out as you're trying to explore and you have more time. So it can span your whole life. And I think that's part of our goal here, is to bring it to people's consciousness. It's not something we talk about. It's a little bit embarrassing because we just don't, our society doesn't really talk about it, but you'd be surprised if you brought it up, how many people are experiencing the same thing.
So along those lines, let's say you are having one of the things that you listed. Who do you go see, and how do you get to a pelvic floor physical therapist?
So to get to someone like me, obviously, we have things like these podcasts, we have social media, we have the internet. So you can easily, let's say, Google someone or Google help. There are some, in fact, I was looking a little bit earlier today. There are things on YouTube. There are a lot of well-known hospitals and things like that that have pelvic health programs. So the information generally is out there. It's my belief that if you have any inclination, if you're even searching for something, go see a pelvic floor therapist. And you can easily access that information online. So I would look at your area. You don't have to travel that far, especially if you're in a kind of a metropolitan area, such as where we're at. So you have a lot to choose from. APTA, which is our American Physical Therapy Association.org. If you search under women's health, they have a list of people. There are places that I have taken classes through IAHP. I think it's International Alliance of Healthcare Providers, and that's my visceral manipulation courses and things like that. They have a database for anybody who's taken their courses. So it's easy to find reputable pelvic PTs out there. They're not all created equally, but I think if you are already searching and you have some of these problems, you should call and make an appointment somewhere.
I want to connect that in. So I forgot to mention this when I first introduced you, but Holly is also a certified lymphedema specialist. So I want to connect these two things because the pelvic floor and the lymph both are helping the body drain. So what are things that people can look for and say, okay, maybe I'm just not, my body isn't draining well. Like, what are signs, symptoms, things that people can, because I think that's a big thing that a lot of people have is we'll call it congested. And that can also lead to some pelvic floor issues as well. So what are things that people can look for and say, maybe it's my lymph and that's kind of feeding into all of this?
Absolutely. So I think lymph and our increased knowledge of what's out there as far as inflammation and all these different allergy testing and different diets that are out there to avoid foods that might be inflammatory to each person's body. Lymph goes along with that. So a lot of times lymphatic congestion, you can see as even swollen ankles at the end of a long day. You can see it as bloating when, oh gosh, I haven't really even eaten anything. And I don't know, there's this squishy bloat, or your whole body, your rings don't fit right, your watch doesn't fit right, your sleeves are a little tight. You can see it in your face where you're a little puffy, the bags under your eyes are more pronounced. So visibly, you can see a backup of lymph. I think there's a lot of tools out there like gua sha and different the diets, different pH, alkaline water, things like that. There's a lot of things that directly affect our lymphatic system and that are more talked about now. It's about detox. It's about listening to your body. But if you notice that, again, something like that is going on, it doesn't hurt to seek out some professional advice.
Do you see correlated maybe having a hard time eliminating either bowel or bladder goes along with lymph congestion?
Absolutely. Absolutely. Again, the detoxification type thing. If you're not able to get out the toxins, which come out in our waste or urine and your bowel movements, you're going to most likely have some issue also with backed up lymphatic system.
Which I don't think also gets like tied in and talked about. So I love that you do both, because both those things I think are so connected, as our detox pathways. I want to go back to talking about bowel and bladder function. Let's talk about norms. What are the norms of what is my bladder meant to be doing during the day? What is my bladder meant to be doing at night? Same thing with bowel function.
So everybody's different. There's a wide range of normal. I'd say generally, if somebody's eating with any kind of regularity, a well-balanced meal, you should be going at least once a day. I mean, just think about it. You're eating throughout the day. Where does all that go if you're not also eliminating that at some point? And we have all had, even if we're not daily poopers, we have all had those times where, okay, 2 days, 3 days, you don't feel well. You're bloated. Your stomach is tender. You might be having cramps. You might be having partial bowel movements, and it hurts to sit even. It's uncomfortable. So, I mean, there's that. I would say once a day. Now, if I'm seeing somebody later in life and they've always been constipated and they say, quote unquote, never have gone once a day, it's always every other day. Okay, fine. You default to their normal. So if they're coming to me and they're going 3 days without a bowel movement, that's a problem. But our goal would be to get them back to every other day then. Bladder-wise, I always say you should be able to sit comfortably through a movie, a couple hours, without having to run to the bathroom to go pee. You should be able to sit through a nice dinner uninterrupted. You should feel, with both bowel and bladder, you should feel relieved. Like, that was a good pee. That was a good poop. You should feel that way. If you don't, there may be an issue with retention in the bladder, retention in the bowel. At night for urination, you really shouldn't have to wake up if you've emptied your bladder before you've gone to bed, maybe once. But after that, it can become disruptive and it's difficult for you to get back to sleep after you've been woken up 2 or 3 times. And then that's another issue. So I would say that's our general norms, but everybody's different and there's a wide range of normal.
So speaking of bowel and bladder function on that topic, talk us through what happens to the bladder as we're drinking water throughout the day.
So we drink water. I don't know the rate of urine production, but there's drops. There's always going to be, if you sit at the toilet long enough, there's going to be a trickle all day long. We produce urine constantly, basically. So ideally, you're drinking, eating, you're pulling that fluid from your intake. The bladder is filling. It expands up to the bladder it's a muscle, but it's like an empty sac. And it fills up to a certain point. There are receptors in there that signal your brain, I'm full, my bladder's full, I need to pee. That's the urgency sense. Your sphincter, like urethra, further down in the bladder can hold, that's where you hold your pee. You can hold it so you can get to the bathroom. You can get so full that can no longer hold till you get to the bathroom, and that's where you leak before you get there. But that's it's a matter of expansion and contraction where it's pushing the urine then out and hopefully completely emptying. So you can go for another couple hours before it's full again and you have to go.
So let's talk about what happens to the pelvic floor as that's happening. So what is your pelvic floor doing as your bladder is filling?
I mean, as your bladder is filling, it should be fairly relaxed. I mean, it's just there. The bladder is not sitting on your pelvic floor muscles. It's up above in your pelvis, but it's sitting quietly. Pelvic floor should be nice and relaxed. When you get that urgency, that's what causes you to do a little bit of a Kegel, where we're squeezing our muscle and we're like, I don't want to leak. You may feel like you need to, so you're going to squeeze. And you can possibly hold that until you get to the bathroom. So the pelvic floor, in response to that signal, is doing a squeeze to try to keep you continent.
Perfect. Let's talk about bowel movements in terms of consistency, texture. I know nothing that anyone ever wants to talk about, but I think there are important delineations and distinctions to be made when talking about a bowel movement, because not all bowel movements are created equal.
Not at all. I believe it's the Bristol stool chart. You can pull that up online easily, and it will show you what a proper poop is supposed to look like. It should come out in a nice cylindrical, congealed swirl, I guess, ideally, the shape of your colon. And you should just be like a toothpaste, just squeezing that right out. no pain, no blood, no straining. In fact, no pushing at all. We've all been like, oh, I got to go, pushing out. You shouldn't even have to do that. If you find yourself pushing, bearing down like that, you might have a tendency toward a harder stool, or they would call that constipated. It can also be referred to as a consistency thing versus not being able to go regularly kind of a thing. So yeah, it should be smooth and in one piece and quite long. You can look at that chart and really see and compare. And sometimes that is indicative of what you might need in your diet, like more water, more fiber, more movement, things like that.
Speaking of movement, let's talk about pressure management, because our pelvic floor is the end of the line. It's the end of our pressure management system. I know we make a lot of jokes about this as humans. We talk about like gas and leaking. And so tell us some norms and what's actually happening in the pelvic floor when we're having these pressure management issues.
Yeah, it's all pressure. It's all about pressure. So it can be looked at as our body is always wanting to be in homeostasis. We always want equal pressures everywhere. So if we're having issues with leakage or issues with gas, like holding that in, I always say you should just, hey, you got to go, you got to go, you got to toot, because you're going to be squeezing your pelvic floor otherwise. The danger in that, so if you're in a profession or in a place that you're not able to go to the bathroom when you feel that urge and you're squeezing and you're holding and you're squirming, what's happening with the body is you're teaching it to not listen to the cues that it's giving you. So you may be, if you do this for years unchecked, you may be giving yourself a problem with retention where you're not able to empty. There's a chance you could overstretch your bladder because it actually gets too full. That's another medical emergency. And it can back up into your kidneys. This is extreme cases, but it is possible. So to honor your body's cues for letting things go, because it's giving you any kind of urgency, is giving you a cue that, it's time to relax the pelvic floor actually and go. So honoring that is really important. And when we don't honor that, ignore it for too long, that can cause other problems.
Let's talk about coordination, because we often think about coordination being a sport or doing a physical activity. But just in my own experience, I've noticed that a lot of people who have pelvic floor issues also have some poor coordination with their pelvic floor muscles. Let's talk about coordination and what your pelvic floor is doing on a regular basis, when it's meant to be more contracted, when it's meant to be more relaxed.
So again, in response to pressures, your pelvic floor will tighten up. Think about when you're coughing, when you're sneezing, you do what we would talk about as a Kegel. You squeeze to protect that force that's coming down through your pelvis. So when pelvic floor muscles are relaxed, I always think about, it's easier probably to think about your actual diaphragm, your breathing diaphragm. It should actually mirror the movement of your breathing diaphragm. So if you imagine breathing in, your diaphragm actually going down. If you're sitting down, the diaphragm is actually going down toward the floor, giving your lungs more space to fill. And then as you exhale, it contracts and it moves towards your head. And your pelvic diaphragm should be doing the same thing. The problem with the coordination thing I see most with that is with the breathing and how it actually does the opposite. The pelvic floor goes against your breathing diaphragm. And then there can be a problem with these normal bodily functions like defecation and urination. And when you ask someone to do a Kegel, they're actually bearing down and they're not pulling up and in. And they don't feel it. They think they're doing what you're asking them to do. And I think that happens quite often, which is why, the easy thing to say, a blanket statement when you're looking at courses or article, just do a Kegel. And then there's the danger, because there's a lot of people doing it incorrectly. I've read up to like 80% of the population does it incorrectly, even after instruction, one session of instruction, they're still doing it incorrectly. So to just tell someone to squeeze, 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 and that's your problem, that's kind of a dangerous thing. And it's not going to be right away. You're not going to end up in the hospital or anything like that. But you can create a longer term issue and then confuse the body even more and make it more difficult to rehab once you do see a specialist.
Yes. And going right along those lines of chatting with people and just having done a pelvic floor rotation and seeing people who've had some coordination issues, it generally shows up somewhere.
Absolutely.
Like you're not, if you have an issue, it is going to show up either when you're having a bowel movement, either or when you are laughing or coughing, like something is not going right and we kind of laugh it off. So if you're feeling like something isn't quite right, again, like Holly said at the beginning, go see someone who's going to check it out because you're likely right.
Right. We shouldn't be leaking when we're laughing and sneezing and coughing and lifting, regardless if you've had a child or not. I don't care what age you are.
Yeah.
In our 80s, it's really not necessary for you to be leaking. And I think we write that off a lot in our society.
As being geriatric.
Geriatric. Oh, well, that's just what happens to your body after childbirth. That's just what happens when you hit menopause. And that's just not true. It doesn't have to be like that.
Speaking of menopause, let's talk about the changes that happen in those tissues, because I know people who are about to enter that age, and let's talk about like what tissue changes there are and what a quote unquote normal tissue is like, and then how tissue can change.
Our female organs love estrogen. So that is what is steadily depleted some more quickly than others when we hit the change. And that perimenopause is when could be 10 years worth of time where our hormones are they're fluctuating and they're trying to get back down again to this homeostasis, but your body's no longer producing things at the same rate it used to. Our pelvic floor muscles and tissues down there will hypertrophy because it's not needed as much, perhaps, for certain functions like childbearing, because you're not going to be having a child after you've hit menopause. So the body is thinking, well, we don't need those anymore now. We're active people. We want to be outside and jog without leaking. We want to have intercourse with our partner still, So we still need those muscles, and they respond. They miss their estrogen. They need that to be plump and healthy tissue. A lot of times the tissues they'll shrink. They'll become more, I say, dry, and the tendency to have more pain or discomfort with intercourse or exam or even just sitting, anything that would involve the pelvic floor, you can have some pelvic pain or discomfort there. At the opening, especially, because we also sit there. So it's very evident to people if they have pelvic pain. I would call it introitus or like entryway pain. That's what we sit on. And that tissue is very, very sensitive to the lack of estrogen, as is our bladder. So bladder diagnoses, incontinence mostly, and urgency, that kind of stuff can be really ramped up in menopause.
And are there like, not blanket, but what are things you can say, hey, this is a good path to go down? See a pelvic floor physical therapist, and what are other things that people can do for that?
I would also see if you're more natural, naturopath, DO, somebody who does bioidentical hormones, perhaps, which could be your traditional, gynecologist. They would be able to advise you as far as and respect the path you want to take. Some people don't want to take hormone replacement, and they have histories of cancer and things like that, which it's definitely something you need to consider with your treating physician or practitioner. I think there's supplements, there's creams, there's other things you can do. It doesn't have to necessarily be pharmaceutical. And I think that's very individualized and up to the person. Just know that you don't have to live with something that is making you feel uncomfortable or painful.
Let's talk about gynecologists. I think this, no. I think this is a conversation that we've had in another time is, I hear this, and I'm sure you hear this, like, I went to my gynecologist and they said nothing is quote unquote wrong, but I'm having issues. And so I want to talk with you about distinguishing what does a gynecologist do versus what does a physical therapist do, so that you wind up in the person's office that you need to wind up in.
What happens now is that because the information is so out there and readily available, the patient, myself, yourself, if you're going to try to seek out a practitioner, you already know that you want to see a pelvic floor PT. You already know that. So perhaps there's a gateway of insurance that you might have to follow if you want insurance to be paying for your visit, in which case you do have to see your physician. And every state is actually different with that, I believe. But I think if you just go in and you say, I'm experiencing this X, Y, and Z, and maybe you feel dismissed or that your practitioner is not not hearing you, you can straight ask for, if it's a prescription you need for insurance purposes, you can just straight ask for a prescription. I would like to see a pelvic floor physical therapist. May I have a prescription? I have yet to see a physician that would say no. I think they might have the attitude of, well, you could try it. I don't know that it's going to work, if they're against, for whatever reason, PT, but I don't think you'd have a problem getting the paper. Now, in most states, California, you can seek out a PT on your own, still go through insurance up to a certain amount of time. I believe it's 45 days or so, and at which case then you need a physician's script approval, whatever you want to call it, but you can self-refer to a PT. And if you just want to go on your own and pay cash, you can do that too. And I think that's where, in our healthcare system, I'm sure you've all experienced the concierge medicine and things like that. So they're not bound. People can get the wellness healthcare that they need without being bound by insurance.
Let's talk about like the actual diagnoses differences between what we're doing and what gynecologists are doing.
So PTs cannot diagnose, first and foremost, right? So I can give my opinion. I've been practicing for 20 years. I've seen a lot of things, but I cannot diagnose. Gynecologists are physicians, MDs, they can diagnose. And I would always default to the physician as far as an actual diagnosis. Now, some of these issues that we deal with require pharmaceuticals, they require medication, they require things that need to be monitored by a physician and prescribed by a physician. There are times in issues like prolapse that require ultimately a surgery, which obviously we as physical therapists can't do. And it's always good to have established care in our area. In my referring physicians group, they do not push surgery. They're very kind and they validate patients' feelings and let them take their time. None of this usually is an emergency. It's a huge inconvenience. It's very uncomfortable, but it's not usually an emergency. So people can wait. And sometimes with PT, things can improve to a point where they don't feel like they need surgery or any more intervention at the time. So they can conservatively treat it. And maybe eventually 10 years down the road, they might need more surgical intervention, but they're able to manage it. And I think a lot of that is what we do, is also management of expectations. There's a certain point in anything where it's too bad. It's gotten too serious that we're limited in the correction that we can help our patients with. But that may be enough for a patient to live comfortably. So I guess that's the difference, is I like to work with my physicians still, because I can consult with them, can ask them, opinions. I can help the patient communicate things to them where sometimes patients have an issue, they can't develop that rapport. They feel intimidated speaking with their physician, and I can help them with that.
I would say, just adding on to that, I think a lot of times people want a diagnosis, but what they have isn't diagnosable because it's a coordination issue, it's a voiding issue, and those things don't necessarily have a quote unquote medical diagnosis. So when people are going to seek out, and this is just my experience, what I've seen, when people are going to a gynecologist saying, these are my symptoms, they come back and say, well, my gynecologist didn't find anything. I don't have any disease. I don't have any quote unquote disease process, but something still isn't right. And so I think that that's sort of like the void that physical therapists fill is, okay, there's not a quote unquote disease, but there's something musculoskeletal, there's something neuromuscular, there's something pressure, like there's something going on that doesn't have a quote unquote diagnosis.
Absolutely.
And that's, I think, the void that we kind of fill. And that's the niche that we are in.
Definitely. And I also believe that we're so diagnosis focused because of the way our medical system is, the paradigm of our medical system, healthcare system, if you will. We need a diagnosis and we're going to treat that. I am more of we're a wellness focused place. You don't feel well. You don't feel 100%. It's my job to try to help you feel better. Diagnosis or not, it doesn't change how we treat you. And it's always treating your symptoms. I might be able to see your shoulders doing better, your pelvic, your pelvic floor muscles are doing way better, and you still say you have symptoms. Then we're not there yet. We're still going to be working on it because it's your perception and how you feel. So it's a lot of subjective measurement, which is not how our healthcare system is run. We want tests and measures and numbers and quantitative data, and that's just not the human body.
Yeah. It's a part, but not
It's a
the
part.
whole thing. Yeah.
Right.
Agreed. Let's also talk about periods and what happens to your uterus when you're on your period and like what is going on, because it feels sometimes very mysterious. Like now all of a sudden you're bleeding.
Right.
And like I feel like health education did not help me understand what was going on with my uterus and why my body was doing this.
Definitely. So when we have a period, it is our uterine lining being shed. That's where the bleeding comes from. It was preparing throughout our menstrual cycle. I won't go into all the detail, but you are preparing for pregnancy. So it is slowly growing the lining, thickening the lining in the uterus to prepare for an egg to be implanted and give that a space to do that. When that doesn't happen, we have a period and we bleed. So when that's happening, as you can imagine, the lining is getting thicker, your uterus is getting a little heavier. Things drop. So a lot of us can feel that pelvic pressure. Some of us in the middle of the cycle, you're ovulating, you're releasing an egg. Some of us can feel that abdominal pain on the right or the left. It lasts for a second, but you can feel it. Some people the uterus will drop. There'll be more pelvic pressure. Things will get more swollen, if you will, down there. You might feel like, oh gosh, it's an ache pressure. You might have back pain related to that pelvic pain in the joints and the bones, because when the uterus drops, there's fascia, connective tissue, ligaments that are actually suspending that uterus within our bony pelvis. And when things are dropping and it's pulling on those ligaments, you can feel, oof, my back. So you'll feel that. You can feel that. The cramping is again that uterus trying to shed that, push out that lining, but also your body, your lower abdominal muscle, just in response to all of that inflammation coming through at that time of the month.
So ideally, what does an ideal period feel like?
Again, wide range of normal. And it would be unrealistic, I think, for somebody to have very, very painful periods all their life to have a goal of having completely pain-free periods. That's just an opinion, but it shouldn't be debilitating. And I think with young women, especially depending on their home life and how mom or the woman in their life, if they have one, has been able to communicate with them what their experience has been, because a lot of times it's a genetic thing. There's a genetic component of grandma had that too, mom had that too. Ooh, I always had painful periods too, So if there's no communication and the girl's just left on their own and they just think it's normal. I've always had painful periods. It's always been really heavy. I don't know. They don't know any different. So it shouldn't be debilitating. I think it's fair to say there should be some discomfort. There'll probably be some discomfort. The bleeding should last from 5 to 7 days, or I'd say maybe 3 to 7, again, the range of normal. Usually it's a little heavier in the first few days, and then it tapers off to spotting. You shouldn't be bleeding through multiple pads an hour. I think that's safe to say that's not, say normal is a really difficult word. It's debilitating when you're having to go to the bathroom 3 times an hour because you feel like you're bleeding through your pad, a tampon, whatever it is. I think that's indicative of an issue, like something that's not normal, not right, and that you don't have to, there's probably something you can do to manage that, whether it be through physical therapy and or birth control pills or something of that sort. It's something to look at if you as a person are feeling uncomfortable, or you feel like, gosh, I don't want to go to school. If you're in high school, middle school, I don't want to go to school because I'm on my period. That's horrible. That's not okay, in my opinion. And you should have somebody that's supportive of you and figuring out how can we make this better? Even at 13 years old, how can we make it better?
We had this conversation a few weeks ago about what we use when we're on our periods. And I was like, Holly, I have something very scandalous to say. I don't use tampons anymore. It just doesn't feel right for me to like stop the flow. That no longer feels like what I want to do. And you were like, I feel the same way. We're like, what? Okay, I thought I was the weird person who doesn't want to use a tampon anymore. Like that was so cool. And it just doesn't feel like what I want to do.
I want it to come out.
Yeah.
I don't want it to be pushed up in there. For me, it's nothing about being ashamed. There was a time in my life, I think, middle school, younger. I think I started my menses in 6th grade. So 12, 13 years old. And you don't want to, if you're one of the first, you don't want to talk about it. You don't want anybody to know about it. Hiding it perhaps with a tampon, which I did not start with until middle school, maybe. That's not an issue anymore. I don't really care what other people think. But to me, I feel like I want to just get everything out.
Yep.
So yeah, pads it is. A cup, Diva cup. There's so many other cups out there. I have a hard time. My uterus is pretty up and tucked up there. It's really hard for me to use without an overflow situation or putting it in an improper place. And then I am in a public restroom and have to empty it. That's not for me. So pads it is. And there's nothing wrong with that.
We are pad sister.
Absolutely.
So now I want to talk to you about pregnancy. Let's talk about, in an ideal world, what pelvic health looks like throughout the course of pregnancy and postpartum.
Absolutely. I think every woman before they have a baby should have a pelvic floor exam. Look at, like you said, the pressure systems, look at how they're breathing, check the Kegel, check the strength, see if they've had talk about their periods, talk about back pain, talk about hip pain, talk about anything that connects to the pelvis. I think that would be amazing. That would be my dream. If everybody had a baseline measurement and they had that in their phone and they could say, look, this is where I started. Pregnancy will change your body every single day. You're going to feel something different. You're going to start looking differently. And again, a wide range of normal, but nothing should really be debilitating. You're going to feel pressure in your pelvis. The belly is going to grow. You're going to have that relaxin hormone circulating, preparing for things to stretch and open up. So there's some instability perhaps in the pelvis and in your joints. The pelvic floor is, as we talked about before, against that pressure as a baby grows. It's pushing against that pressure. It's working really hard. You might have toward the end, more issues with incontinence, coughing, sneezing, difficulty with bowel movements, just because the baby hormone related too, but the baby's in the way. There's takes up a lot of space in your abdomen and your organs get pushed wherever they can fit. So everybody can have different issues with that. Postpartum, it depends on how the baby is delivered. You could have a cesarean section, emergency or planned. That makes a difference. The level of trauma that might be involved with that. There's vaginal deliveries that can involve episiotomy, where the doctor cuts the opening a little bit larger so the baby can fit, or tear. And you have different layers, multiple layers of muscles that can be torn through. So the severity of that can be widely varied. And usually after, I'd say about 6 to 8 weeks postpartum, it'd be great to have another pelvic floor exam and see where you're at, looking at scar tissue from any of those tears or cuts or surgery, C-section, and addressing mom's issues with any kind of pain or discomfort or any persisting bladder or bowel symptoms at that point. Those acute incontinence, postpartum, things like that should be fairly resolved by 8 weeks or so. If you're still leaking, you still have some pain, yes, time does heal, but I think at that point it's safe to consult with the physical therapist or go back to your doctor and say that, hey, this is still bothering me. Also, I kind of skipped a step right before delivery. I'd say about a month before, it's wise to go into pelvic floor PT and check your pelvic floor and see how ready you might be for a vaginal birth. Most of us still plan on vaginal deliveries, and you can check to see the tone of the pelvic floor. You can teach the mom and the partner how to stretch the opening to make it more welcoming to pass a baby through, things like that. You can teach some pressure points in the back and, the low back and supportive postures. And you can even look at with a biofeedback machine or just manually look at different birthing positions and see what might be ideal for each individual. See where they have less tension. Some might be better in a squat. Some might be better on all fours. Some might be just better on their back, holding their knees up, like traditionally. And everybody's is a little different, but you can get all of that kind of assessed before you deliver, and that can make it a much easier process.
Something that I learned that I would have never associated, but generally when we're in pain, our pelvic floor muscles contract. And I think that is probably I would say, no, I haven't birthed a child, but I'd say that's probably the most difficult part is that you have to override that system of your pelvic floor muscles contracting because your pelvic floor muscles actually have to relax in order for the baby to come out. So if you don't know what it feels like to relax your pelvic floor, that's when I think people tend to have a lot of tearing, is because they don't know what the relax feels like, which is, I can't even imagine how incredibly difficult that is when you're having a lot of contraction pain.
Right.
You have to override and tell your brain, okay, I understand I'm in pain. And I also need to relax my pelvic floor so that the baby can come out.
Absolutely. Yeah. It's a magical thing, childbirth.
Yeah. So yeah, I would just, if you don't know how to relax your pelvic floor, I would say, right, please come see a pelvic floor physical therapist. They can show you what that feels like, teach you how to find that, because you don't want to try to be finding that while you're birthing if you don't know what that feels like. That is not the time.
No.
That is the time to practice something that you already know how to do.
I agree. Absolutely.
Don't worry, I'm coming to see you. Okay. What are any other tips, tricks, things that you've learned over the years of being a pelvic floor physical therapist that apply to everyone?
I think listening to your body, which we touched on, if it doesn't feel right to you, it's probably not. So listen to your body. Talk to as many people as you need to get the help that you need. I hate that it takes a lot of my patients so long to get here.
It took me 8 years to find you.
Yeah. But then I did. Be me. And I'm so grateful. I'm so grateful that it was me.
Totally.
I've known you for so long now. And you're just a light. But it doesn't have to be me.
Yeah.
Anywhere, whatever you need to get, for somebody to hear you, to get you the relief that you need so that you're not dealing with whatever you're perceiving is not right. Don't give up. There's people like me, like us out there that can hear you. And if we can't help you, because I'm not a miracle worker. I've been called that, but I'm not. And I hate that. It's a very, it's a scary term because I'm not.
Right.
But I like to see the whole person. And over 20 years, I've developed a lot of great contacts and people that I trust that I can refer to. And I think you just need to find somebody that's going to listen. And it may not be me that can help, but I'm sure I know somebody that can.
Absolutely.
So I think that's a general one thing that I see a lot still. Just, I hate that it takes so long for people to get the help, but there are people out there that can point you in the right direction, if not actually be the ones to help you as well. I still advocate that everybody should have a pelvic floor evaluation. I don't care where you're at in your life. So that you can talk about this stuff as it specifically applies to your body. And you can notice when there's changes or issues way quicker, because awareness is the first step for everything, right? And if we are unaware, blissfully unaware, and something goes wrong, you first think, oh my gosh, this is weird. I'm the only one. And you don't say anything at all and it goes on for years. Or you're just, it's going to come at a time when life is overwhelming and you put it off because it's not, again, not life-threatening. It's inconvenient. You put it off. That's typical female patients, typical my patients, and it doesn't need to be like that. So I think those are the two big things. Very, not even PT specific necessarily, but as women, what we need to do, what we should do, and then not be afraid to talk about it. Talk to your friends. I guarantee you're like, oh, you too? You too? Really? Yeah. Yeah. We can relate to each other a lot more than we probably think.
And then when you find a physical therapist like Holly, then you say, hey, this is what's going on. Like, is this normal? I ask Holly constantly, is this normal? It's just a nice check-in. Someone who knows the body really well, who's seen my body over years. Okay, is this normal? When something crops up, okay, do I need to address this? Am I always like, no, what's happening? As a provider, I'm always looking for things too. So we had this conversation last week of like, am I too worried about something? And so, yeah, I think there's that like, okay, great. I already know that I can come in and see you, have a check-in, say, great, this is what I'm feeling. These are my symptoms. What do you think? What's your opinion?
Absolutely.
I'm going to take off my own doctor hat and let you be my practitioner. And so, yeah, I really appreciate that. And I think that that would be so ideal if everyone had that person where they could go and check in and say, this is what I'm experiencing.
Definitely.
What do you think?
Definitely. I love that. That would be ideal.
Okay, please plug your clinic. If someone wants to work with you, how do they do that? How do they find you? What's the best way to connect?
We are located in Huntington Beach, California. We have a single location at the moment. We are online. Our website is lokahi, LOKAHIPT.com.
I'll link it.
And we are on Instagram under the same name and on Facebook. And trying to, increase our presence on Google and play that algorithm game. But, we are there and we are available. And again, you don't have to see me, but if you have questions, I'm happy to entertain them. If you shoot us an email or a DM and you maybe don't live here in California, but you're looking for a place to go in your state, I can kind of help point you in the right direction. I just believe that everybody should get the care that they need.
And you treat lifespan.
I do.
So you're treating kids up through older adulthood.
Absolutely.
So yes, please reach out. She's amazing. And thank you so much for joining me on today's podcast.
Thank you for having me.
You've been listening to Authentically Shawna with Dr. Shawna Burke. The information contained in this podcast is provided for information purposes only and is not intended for the purpose of diagnosing, treating, curing, or preventing any disease. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for statements made by guests. Thank you so much, and we'll see you next week.